So you know who we are, and we've been doing this for a really long time. Let me just ask you a couple of questions. How many of you guys have had some sort of education or formal training in how to document in a medical record? And did you get it in medical school, residency? Where did you learn how to document? Residency. Okay. Can you tell me a little bit how you learn in residency? Is it a senior resident teaching a junior resident, or is it a supervising physician teaching you how, or is it the way they're doing it at a certain hospital you're working at?
And we have a CPI, that all that stuff.
Okay, so you do. You have a clinical documentation improvement team. Fabulous. Okay. So how many of you guys think you're good documenters? A couple. Okay. So if you had a claim or a lawsuit and we were going to put your documentation up on the screen about this big for a jury, do you think it would fly and you get a defense verdict? Okay. Well, we're going to talk to you about this topic, and it's really, really important because what happens is by the time a claim or a lawsuit comes to fruition, it's about 3 to 5 years from the actual event occurring. So memories get lost. The patient's memory changes a lot. And it's your documentation for the most part that's going to speak for you when all is said and done. You might be able to go back and review the record, but for the most part, unless that person was a pain in the butt for you, you're probably not going to remember that patient. So it's going to be your documentation that speaks for you. So we're going to go through this afternoon and talking about how important it is for you to document. Not that you have to document the world, war and peace, but document enough that it protects you yourself if you're ever named in a claim or a lawsuit. So we have some objectives today. Name 3 elements of good documentation. Provide 2 examples of poor documentation. Explain why there's a professional liability risk associated with copying and pasting. And describe effective ways to document, including using your phone, text, email communications in the medical record. So hopefully you guys can see this. Patient comes in, and this is taken out of a live EMR. We don't make this stuff up. Patient came in complaining of a rash. So the subjective is the patient complains of a rash and an infection on their left cheek, times 4 weeks. Also has a mole on his back that he would like to get evaluated. Patient complaining of rash for 2 weeks on his left cheek. He also developed a left rash in his left axilla under the right skin fold on the right side of the chest. He's not on any medications. This is what the practitioner documented. Skin denies rash, itching, sores, and bruises. What's wrong with that documentation? Anybody? It's very conflicting. A lawyer would have an absolute field day with this note. I'll give you another example. The patient comes in complaining of dizziness and lightheadedness and fatigue. And this is what the practitioner documented under the ears, nose, and throat. Denies hearing loss, pain, vertigo, or tinnitus. Again, conflicting information. Right? These are drop-down boxes in an electronic medical record, probably much like the one that you are using. And so it's really, really important when you're using drop-down boxes that if everything's within normal limits, that's great. But if something's abnormal, if you have to either document it somewhere else or be able to show that you've got something that's out of the ordinary. What they did in these 2 cases, they clicked the drop-down box and it comes up with basically everything's within normal limits. And they didn't do any free text to say that this patient had vertigo or dizziness. So you can see how easy it is to not only get yourself in trouble legally, but also from a malpractice standpoint. So the medical record, it's got 2 main components to it. It's a communication tool for the entire healthcare team. Okay, so that's your nurses, your doctors, everybody who's putting their hands on that medical record, the physical therapist, the occupational therapist, all the specialists that get involved. So it is the communication tool that's telling you how you guys are managing the patient's care as a care team. And it's one piece of evidence of the care provided, but it's a very important piece of evidence. And remind yourself, not only is this from a medical standpoint, but you've got insurance companies looking at medical records, you've got legal people looking at medical records, you've got the patients, their family members looking at medical records. So when you're documenting, remember, you're not documenting for yourself, you're documenting for the larger picture. Remember, when you document, if you had to go back and memorialize the care of that patient, and you read your medical record, it should be showing you how you're managing that patient's care. So we want to look at the credibility of memories and documentations. Like I said at the beginning of the program, memories fade over time. I don't know any of you guys who can probably remember what you did last week. Sometimes I don't even remember what I did yesterday, let alone 3 or 5 years down the road when a claim comes down the pike. Okay. And their memories, time to dated, when recollected, will be days, weeks, or even years later. So it's really, really important that you're documenting the date and the time of your documentation so that it is relevant. And the medical record documentation for at the close of time that the care is provided. So what we're looking for when we are reviewing medical records are these things. Do you have a current health history? Review of SOAP notes or review of systems, subjective, objective, action, and plan. Are you using checklists like medication lists, problem lists? How are you tracking and following up on your reports and procedures? So say you said you have your results or to see a specialist, how are you tracking to make sure that patient saw that person or got that lab result and got the information back and we're able to close the loop? And what's the plan of care and treatment? So I'll tell you a story. We had a case, and these are cases I'm talking about that are not mine, and these are closed for several years. But we did have a case where the health history on a smoker, it was 10 years old, and back 10 years prior, he told the physician that he did not want to be sent to the emergency department if he suffered from any lung complications. The health history again was 10 years old. When he actually developed pneumonia, he went to see his practitioner, and the practitioner based what he decided to do with the patient on that 10-year-old note. And so he did not send the patient to the emergency room. The patient later died the next day at home, and his wife brought claim against the practitioner because she said that he didn't do what he would have done, which would have been to send him to the hospital so he could get appropriate treatment. They actually did settle the case. It didn't go to a jury trial, but they settled the case, and it was pretty significant. And it was because the practitioner was based on a health history that was very old. So we're not saying you have to update it every time you see somebody, but every time you see them, you want to make sure you're updating the allergies, the medications, because those things can change overnight. And most patients are not going to think to tell you when there's a change of something that's going on with them unless you prompt them to. So what we see is best practices. We want to see your documentation is accurate, contemporaneous, and it's legible. Pretty much legibility has gone by the wayside with the advent of the electronic medical record, but there are still doctors out there paper charting. So what the medical board says is that you can't read your handwriting. It's considered unprofessional conduct. So you want to make sure that your handwriting, if you are still handwriting notes, is legible. And remember, you're writing it for somebody else, not just for yourself. You might be able to read your scribble. That doesn't mean your colleague can. Make sure, like I said, you're obtaining a health history and past medical records for any new patients or patients you've never seen before. We see this all the time where a new patient walks in the doctor's office and the doctor's office has no medical records from a prior treating physician or a primary care physician, and is trying to get a health history from the patient or the story, and it ends up either diagnosing the patient with the wrong diagnosis or it's giving them the wrong treatment because they don't have the prior records to fall back on and review. Okay. You want to make sure you have a differential diagnosis. Most of the time, I don't know, I know there's a multitude of specialties in here, but a lot of times you might have a patient who comes in, you really just don't know what's going on with the patient. I was in to see an orthopod a couple of weeks ago, and he's been in business, practicing probably close to 40 years, pretty much could tell anybody what's wrong with them. And I went in for knee pain, and he made me go through a whole bunch of things with my knee so that he could look me out, and I sat back on the exam table and he looked at me and he goes, I have no clue what's going on with your knee. And I had so much respect for that physician because he said, he didn't know. I'd rather him tell me I don't know than to say, oh, it's a meniscus tear or it's arthritis or whatever it is. He didn't. And he said, you know what, we're going to need to do X, Y, Z so that we can make more differential diagnosis for you going down the pipe. So you want to be able to say to patients, I don't know. I got to look into this further. Okay. A lot of times doctors are afraid to say to the patient, I don't know, and it's okay to say that. And document in the medical record that I think it might be this, or I think it might be this, but we're going to do this, this, and this to rule those out. Follow-up care and need for return visits is very, very important, especially if you're working in outpatient clinics after you get out of your residencies. When you see a patient for an acute condition and the condition is solved, you generally want to put in there follow-up PRN or when do I want to see him again? In a month, 2 months, 6 months, a year. You want to definitely document the patient's care because this shows that you are managing the patient's care and there be no potential claims of possible abandonment of care. Okay. You want to make sure that you're documenting the patient's health concerns and their questions. Big thing that we laugh about when we go to see doctors' offices is they'll say, come in with 3 of your main things that are going on with you. If you have more than 3, you're going to have to make another appointment to see the doctor because they can only handle 3 items at a time. Now, granted, a lot of this is based on time constraints for physicians and insurance billing, but you definitely want to document what the patient is telling you or their family member or caregiver is telling you. Any new medications or refills that are being prescribed, and lab tests, diagnostic tests, consult, and referral. This is huge. I will show you a slide a little bit down the road about how many lab tests we order in a year, and it's pretty amazing. But follow-up and loss of recall and loss to follow are very, very big. What most judges will say is that if it was important enough for you to order it, it's enough for you to own it, which means if you send Sally Sue out to get a CBC and other lab tests, you want her to see a cardiologist and a pulmonologist, and you want to see her back in a month, you have to make sure that you've got a system in place, even in your hospital systems, that make sure the patient's doing this, you're getting the results, you're following up, you're communicating the results to the patient so you can close the loop, or you're documenting why the patient didn't do what they needed to do. Right? And you also want to document your phone calls, emails, and text messages. And I understand that you guys used, my understanding is St. Joe's uses Tiger Text. I'm not sure what Valley Wise uses. But these are all part of the medical care. If you are, and I'll talk a little bit more about it later in the slide, but you definitely need to document your text messages. We talked about need for return visits within a specified time frame, informed consent and informed refusal. As you guys know, if you're getting informed consent from somebody, it's not a piece of paper, it's a process where you're explaining the risks, benefits, and alternatives of a procedure or a treatment plan that you are suggesting the patient get. You definitely want to document in your progress note that you had that conversation. And as your secondary insurance, you want to get them to sign an informed consent form, because this will show that they'll be hard pressed to prove you didn't have that conversation if the patient signed the informed consent form. Lots of times we'll see an attorney say, oh, the doctor says, well, we did have that conversation, when the patient says, no, we never did have that conversation. And the doctor says, no, here it is in my progress note. And the attorney says, but how do I know you just didn't write that in your note? So the informed consent is your secondary insurance where you've got that patient's signature. Okay. And generally that informed consent has a witness signature as well, which is the person who's not saying that the patient understands what the procedure is that's planned, but they are witnessing the signature of that person signing the form. Okay. Informed refusal is as important as informed consent. If a patient does not want to do something that you're suggesting that they do, document it, put it in quotes if you need to. I can't go get this test because I don't have any insurance. Whatever it is, you can always put these statements in quotes if they state a quote to you, but it's very important that you document patient refusal, because if something happens down the road and there's a bad outcome, we want to be able to show that the patient was a party to the bad outcome to help protect you. Medication and allergy updates I did talk about, and these are really important because these change all the time with people. Flow sheets, if you're using them, conversations that you're having with caregivers and the patients, these are all part of the medical record. Make sure you're using consistent and standardized terms. Obviously, all you guys know what the do not use list is from the Drug Commission, I'm sure. But within your own specialties, there should be certain phrases that are universal against everybody, as opposed to just certain types of people. When I first started doing OBGYN charts, we went out to a pretty large organization here in Arizona, and they had their own medical jargon, and it took us probably about 30 charts before we started realizing that this was what they were using internally, but it was not normally PCOG abbreviations. You want to definitely document your thought process. Like I said, you might not know what's going on with the patient, you can document that. What's the discharge plan? make sure that that is documented appropriately. Your ICD-10 is matching the documentation. That's where your billers come in, and periodically review your own and your staff's charts for documentation. What I can tell you with the discharge plan is about 25% of discharge plans never make it back to the person's primary care provider. So unless the patient tells the primary care provider that they were in the hospital, a lot of times the provider never knows this and goes on treating the patient, not knowing that there might be a significant addition to their health. So you definitely want to document that and make sure you know where these discharge plans are should be going. Copy and paste, it was one of our favorite things. It could be called copy paste, cloning, carry forward, wherever you want to call it. The most important thing about copying and pasting is that if you're going to use that function, make sure whatever you were copying and pasting is accurate for the note that you were documenting. I can tell you right now, and it doesn't take a rocket scientist attorney to figure out that the vital signs cannot be the same 7 days in a row. Okay, and we've seen it. Okay? Or the problem has been solved, but it keeps getting continued on. And I know you guys are busy residents, and copying and pasting is probably a lifeblood for you guys. Given your rotations, just make sure to protect yourself that whatever you are copying and pasting forward is accurate to the treatment plan of the patient. Because we see an awful lot of stuff carried forward that's either in error or has already been solved. Looks like it's still a current problem. And again,
I can't go down the because with this stuff, there's no kind of passes that you know.
Use. Medication allergy fields are left blank. Okay. Lists are not current. The medication history is out of date, or the health history is out of date, like the case I told you earlier about the gentleman with pneumonia. Flow sheets, especially health maintenance, chronic conditions, well visits, and immunizations are left blank. Okay. Unprofessional handwritten notes, no resolution of the problem from the previous visit, or lack of a narrative note. Like I said, you don't need to write War and Peace, but if you think it's important enough to document something about the patient's condition, go ahead and do it. It's not, you can never document enough. Okay, but these are the types of things that we see all the time. But basically what happens is your jury, when they look at this kind of stuff and it's plastered up on these big screens, when they look at this and they think it's substandard documentation, then they make the leap and they think you're giving substandard care. Not that that may be true, but that's how the leap that they will take. So again, the big thing is tracking and follow up. This is astounding to me. Physicians and other nurse practitioners, PAs, order about 14 billion lab tests per year. That's a lot of labs. And about 70% of the medical decisions are based on these labs. How are you going to make a medical decision on a patient if you don't follow up and get the lab back? And I can tell you, there's a large piece of things that, we see this and we're helping practices all the time. Shore up their recall and tracking and their follow-up, because once you send the patient out to the lab core, Quest, whoever it is you're sending them to, where do they send it to their own doctor's office? If you don't have some sort of system in place to track who you sent for to see a specialist, who you sent to get some lab work done, how are you going to know to follow up with them? If you're just starting practice and you only have 10 patients, you can probably keep it in your head. But once you grow and you've got 3,000 or 5,000 patients in your active practice, you can't remember this. So you've got to have a system in place. You can do it electronically. You can do it on paper. We used to teach medical assistants how to do it with a Zippler file. Every Monday they go through it, go to see it. They call the patient to see if they got it. Once it gets in, it goes to the doctor's desk for sign off and for them to close the loop. So keep it simple, but this is a huge issue in liability cases. Telephone medicine is another big one. Everybody knows we went to telephone medicine. Even though we did telemedicine with the onset of COVID, we are still, for the most part, using the telephone when we converse with patients, especially the elderly patients. The problem with telephone medicine, whether it's during normal working hours or after hours, is you don't have the visual clues that you would you saw them in person, okay? So you want to make sure that the patient is also comfortable speaking with you via the phone, and you're documenting these calls. I can't tell you how many times we see the staff is on the phone with the patient or the doctor on the phone with the patient, giving them lots and lots of medical advice, and nobody's documenting anything. And if you didn't document it, it didn't happen. That still holds true today. So you want to make sure you are documenting not only the calls during the day, but also the calls after hours. And same with email. Everybody, I'm sure, is familiar with how to use email, that it needs to be encrypted, okay, to follow the HIPAA guidelines. And also you want to control access to who's got access to that information and make sure that those emails are landing in the patient's medical record. Because if you're talking about anything besides visit to the doctor's office, like appointment for next Tuesday at 2, that doesn't need to necessarily be documented in the patient's medical record. But if you're conversing with them about their medical care, it needs to go into the medical record because it is part of that medical record. Again, you want to preserve the integrity of the email, make sure that it's encrypted so that the bad guys can't get access to it or a third party. And send only lawful information that's allowed. Super confidential information like psychotherapy notes, drug and alcohol, HIV, AIDS kind of information is what we call super confidential, okay, under HIPAA. And so you have to have the authorization of the patient before you can send that information, okay? Texting, we strongly discourage it, as with most places. The reason being is texting is about 140 characters. Everybody, it's very convenient, but the Joint Commission still says that we are not supposed to be texting orders because they can be misinterpreted. The other thing too is, you know, doctor sends the patient text message and says, follow up SOB. Doctor meant follow up shortness of breath. Patient meant use your imagination. Right. So just because you're using abbreviations doesn't mean the patient understands those abbreviations. Okay. So you want to make sure if you are texting with a patient that it's an encrypted text messaging system, that you're spelling it out as much as you can without using abbreviations to make sure that they're understanding, and that you're also transcribing that text message into the patient's medical record, because even though we don't have a way to do it like we do with emails where we can scan it, you know, I'm sure that's coming down the pipe soon where you'll be able to scan that text right into the electronic medical record. For now, you have to actually transcribe it yourself or have someone transcribe it into the patient's medical record. Okay. And you want to make sure that's happening. And even if you delete your text, your SMS card on your phone or whatever device you are using doesn't go away. There's a thing called metadata that's running in the background of the computers and your phones. And so just because you hit delete doesn't mean it goes away. Okay. And I can tell you, we see this a lot with physicians taking call for each other's practices, and they're getting calls in the middle of the night for patients, and they're texting back and forth with patients, and they're never getting that text into the patient's medical record. However, claim or a lawsuit comes down the pipe, they subpoena the doctor's phone, and there it all is. So you got to remember, you make sure that you know when you're texting a patient, it's part of the medical record, and you want to control who's got access to that as well. Again, the same with email. You want to preserve the integrity, make sure you've got policies and procedures in place. I'm sure Valley Wise and St. Joe's does. Obviously, you want to make sure you're using smartphone applications that are within the organization's policies and procedures that are allowed. And again, you want to make sure that all your texts are included in the patient's medical record. And this includes texts with other care providers, texts with other physicians or healthcare providers that are providing care to the patient, as well as to the patient themselves. So with that, I'm going to turn it over to Karen, who's going to talk to you about some cases, unless anybody's got some quick questions. Okay.
Hi, everybody. I've got some cases to tell you about where documentation was a large part of the defensibility or the indefensibility. Not all of these cases went to trial and were decided by a jury. You may be pleased to know that it's very rare for a medical malpractice claim to become a lawsuit, then to go to trial and for a jury to hear it. Most medical malpractice claims reported to your medical malpractice insurance company die on the vine. And just a few become actual claims where there may be some back and forth with the lawyers. And again, rare to become a lawsuit. So you won't always hear a wow verdict or, some kind of emotional finding by the jury. Some of these cases are just things that were in the claim stage. But our job is to help you never, ever have a lawsuit, or to be like the physician in the first lawsuit I'm going to tell you about, where once the plaintiff attorney subpoenas and goes through the medical record based on your documentation, they decide not to proceed with the case. In our first case, the defendant plastic reconstructive surgeon obtained the patient's informed consent for breast augmentation and implants. The plaintiff had lupus and had been taking Plaquenil and been on a prescription anti-inflammatory for several years. The defendant surgeon had done a few minor but successful procedures on this patient. The defendant also documented in the medical record in an office visit note the plaintiff's choice of quote unquote very large implants. It would have been nice if the physician had documented the size of the implant, but this turned out to be enough to defend the case. The plaintiff's post-op course and healing were less than ideal, including infection, necrosis, and resulting in the removal of the implants and scarring. When it came time to look at this medical record, we saw that this physician had not written an informed consent note that explained or documented anything related to delayed healing due to lupus. But the 14-page consent form contained everything we needed and a few other things. Here are some things that were contained in that consent form that helped the plaintiff attorney make the decision not to pursue the case. Wounds may separate after surgery. Should this occur, additional treatment, including surgery, may be necessary. Wound disruption or delayed wound healing is possible. Some areas of the skin may not heal normally and may take a long time to heal. Areas of skin may die. This may require frequent dressing changes or further surgery to remove the non-healed tissue. There are many variable conditions that may influence the long-term result of the surgery. It is unknown how your tissue may respond or how wound healing will occur. There are general risks associated with healing, such as swelling, bleeding, possibility of additional surgery, prolonged recovery, color changes, shape changes, infection, not meeting the patient's goals or expectations, and added expense to the patient. Individuals with weakened immune systems, individuals with a weakened immune system, conditions that interfere with blood clotting or drugs to suppress the immune system, or wound heal, or have a reduced blood supply to the breast tissue from prior surgery or radiation therapy treatments may be at a greater risk for complications and a poor surgical outcome. Certain medical conditions, dietary supplements, and medications may interfere or delay healing. The plaintiff dismissed the lawsuit. Now, this case happened in Arizona, where the consent form is very important to the jury. You may leave your resident program and end up in a state where the jury doesn't care what was in the consent form and wants to hear your testimony about what you explained to the patient. So while the consent form was very important here, it may not be as important as your conversation and what you note about it if you end up in another state. The U.S. Food and Drug Administration now requires breast surgeons to provide a specific 16-page consent form. And in Arizona, there is a new breast implant law that requires the same and similar information and a 6-page consent form. In Arizona, physicians need to use both or combine them. It just so happened that the 14-page consent form in this case contained everything that was in the now required 16-page consent form. Our next case involves a shoulder arthroplasty. It's here in Arizona. The plaintiff's right arm was amputated after a right shoulder arthroplasty. The plaintiff sued the orthopedic surgeon and the hospitalist in charge of her care at a rehab hospital. The crux of the case against both defendants was whether the brachial embolus was present while the patient was still inpatient and under the care of the orthopedic surgeon, or if it occurred in the rehab setting while under the care of the hospitalist. Expert witnesses for the hospitalist were supportive and believed the complete occlusion occurred very shortly after surgery, maybe even in the post-anesthesia care unit, before the defendant hospitalist ever saw this patient. The defendant hospitalist attorney was initially optimistic, and that changed as the attorney learned new information about the hospitalist's documentation. The plaintiff had obtained a copy of all the records before she was discharged from the rehab hospital. The plaintiff then filed the lawsuit, and on the day of filing the lawsuit, obtained another copy of all the records. So you probably know where this is headed. The defendant had changed the date of his signature in his admitting note between the time the plaintiff obtained the first copy of the record and the second copy of the record. He testified in his deposition that he had not actually seen the patient on her admission date, although he was in the rehab hospital that day. He actually saw the patient 2 days after her admission, and he was afraid his error dating his signature would indicate he saw the plaintiff sooner than he did. Also, prior to the plaintiff's discharge from the rehab hospital, the defendant hospitalist had ordered a consult in the morning, but went back and changed it to stat. So those are a couple of examples of the things that were different between the two records. So while the expert testimony was very hopeful for this physician, a jury never got to hear this case. The defense attorneys were not confident in putting this medical record and this testimony in front of a jury. And so the defendant hospitalist settled his case. Those details are confidential. So the hospital had a shot. I mean, the hospitalist had a shot, but didn't get his day in front of the jury to vindicate his care. And I promise not all of the cases are surgical, and they're not all going to all be breast cases. In the next case, the defendant orthopedic surgeon diagnosed the plaintiff with osteochondritis and discussed ankle fusion or total ankle arthroplasty. The defendant surgeon offered to refer the patient for the ankle replacement. That was a procedure he did not do. She opted to continue to treat with him. Over the next 18 months, the defendant surgeon treated the plaintiff with Depo-Medrol injections and answered the patient's questions about surgery. Early on, the defendant surgeon documented a 30-minute discussion with the plaintiff and recalled drawing a picture for the plaintiff of what her ankle might look like after the surgery. At another appointment, the defendant surgeon recalled an informed consent discussion and again drawing the picture of the procedure. At yet another appointment, the defendant surgeon recalled going over the procedure, the expected post-operative course, the attended benefits and potential complications, including non-union, infection, amputation, removal of hardware, and continued pain. So we're at the point of the surgery, and the defendant surgeon documents in the operative note removing 5 millimeters of tallardome and giving a 5-degree downset in the ankle because the plaintiff wanted to wear high heels. Of course, this patient's recovery did not go well. Hardware was removed and her pain was still unrelieved and even worse than prior to the surgery. The patient sought a second opinion, and that orthopedist documented the plaintiff's foot was fused in a slight plantar flexion to accommodate a shoe. The plaintiff continued to see that second opinion surgeon, did not return to see our defendant. The second opinion surgeon documented the patient's foot was in a poor position for function, and the plantar flexed 15 degrees. The plaintiff sought yet a third opinion from an orthopedic surgeon who suggested that she could consider amputation as resolution to her ankle pain. He documented the plantar flexed 40 degrees. The plaintiff did not pursue another surgery, but instead pursued a lawsuit against the original defendant orthopedic surgeon, alleging he improperly performed the surgery, leaving her foot in a deformed position. The defendant surgeon's expert witness was supportive, saying that the plaintiff's foot was in an equinus varus position before surgery because of a prior medical condition that she had had since childhood. And that surgeons are known to fuse ankles to some degree of equinus position to allow patients to wear high or higher heeled shoes. The defendant explained to the jury that a 5-degree ankle is normal, but given the plaintiff's desire to wear high heeled shoes, the plaintiff agreed to a 10 to 15 degree ankle. The defendant said he and the plaintiff spoke numerous times and at length about the 10 to 15 degree fusion and how it would really limit what the plaintiff could do. The defendant said that the plaintiff understood the risk and wanted to proceed. Unfortunately, our defendant surgeon only documented that original 30-minute informed consent discussion and did not document the discussions that occurred over the next 18 months and never put the picture of the ankle, how it would appear after surgery in the medical record. The defendant surgeon also had continuously documented a 5-degree angle throughout these 18 months and prior. And then we had the experts testifying it was anywhere from 10 to 15 to 40 degrees. Several jurors nodded their heads up and down as if in agreement when the defendant surgeon testified. It appeared that they liked the defendant surgeon And also did the same thing when the experts for the defendant testified. But while the jury's reaction seemed favorable, the jury found in favor of the plaintiff. Now, after a trial, some courts will allow the defense attorneys to poll or ask the jury questions. And there was one juror who was willing to talk to the defense attorney. And she explained that she laughed repeatedly at the plaintiff's experts and shook her head on almost every occasion that they criticized the defendant, because she felt like they were hired guns. And of course, these were the things that they were going to say. She said that while she felt angry at the plaintiff attorney for bashing the defendant, this occurred in a small town. She could not get past the fact the defendant's repeated documentation of the 5-degree angle. She actually believed that the defendant surgeon did a good job, improved the plaintiff's mobility, but the documentation just did not support her decision in favor of the defendant. Got a fallopian tube case to tell you about. It involves transcribing and dictating, and it's not an old case, it's pretty new. The defendant OBGYN diagnosed the plaintiff with unilateral left-sided hydrosalpinx. The defendant OBGYN obtained the plaintiff's informed consent for quote unquote removal of one hydrosalpinx. That was in the discussion with the patient to prevent ectopic pregnancy and first successful pregnancy. But in the documentation, documented salpingectomy. The consent form said consent for sterilization and bilateral tubal ligation. During the procedure, the defendant OBGYN saw problems with both tubes and removed both. And the operative note stated bilateral salpingectomy. The post-op diagnosis was bilateral hydrosalpinx and right ovarian cyst. Following the surgery, the plaintiff attempted several intrauterine inseminations without success. She went to see another infertility specialist who explained to her that she did not have both fallopian tubes. The plaintiff, of course, said, "No one ever told me either before surgery that that was a possibility or after surgery that that had occurred." The defendant OBGYN used speech recognition software for office visits. He did have to testify in a deposition that he was not always consistent at starting it before the appointment began and stopping it after the appointment concluded, that sometimes he turned it on and turned it off at various parts of the appointment and may not have turned it back on. The defendant OBGYN explained that he explained what happened to the patient in the PACU right after the surgery, but did not document that discussion in the medical record. And at this point could no longer recall the substance of the conversation, only that he discussed the actual procedure that was performed. There was a recording of part of a post-op office visit. And I want to read you what the software dictated. The physician did not review this note and correct it before it was put into the medical record and finalized. And so this is exactly how it appeared in the medical record. Oh, also, this physician during the initial interview with this physician, he had explained to our claim representative and to our defense attorney that he was an excellent documenter and that he felt very confident in putting all of his medical record documentation in front of a jury. So this was the recording. Better now? Was it bad? All right. Well, this is you. All right. And so I went to make sure that you have every capability. Okay. All right. So that's both sides. And then, okay, so here is the end product. I removed the tube. See, it's not there. It's not there. I did take a look up, baby, having go inside. We do survey and we look around and we say, okay, what's going on and what's not going on and what's not. So the were one reason for hypersonic thing, unfortunately, is infection, sexually transmitted infection. Unfortunately, okay. So, and then you did have some, scar tissue in a huge over cause fits huge Curtis, which is consistent with me be lonely long time ago having sexually transmitted infection. Okay, and so that's what it is, but it's not going to affect causing long-term problem, but it does kind of answer the question like this. It's kin of kind of leaguer the way it happened. All right, these are your let your belly rate. Orion would have been cheaper fall off, but it was known as the irritating thank you. The plaintiff attorney had sent this physician a dear doctor, I represent the interests of your patient letter, and alleging medical malpractice from the removal of both fallopian tubes. When the defense looked at the documentation, decided this was not going to be a good physician to put in front of a jury to testify, or a good medical record to blow up on a screen just a little smaller than this for the jury to read. So this physician had to settle that case. In the next case, reviewing prior medical records was the issue. This patient came to the emergency department with complaints of numbness and tingling in her left arm. I'm sorry, in his left arm. The defendant radiologist's impression of the chest x-ray in the ED, no acute cardiopulmonary disease with normal cardiomediastinal silhouette and age-appropriate atherosclerotic changes to the thoracic aorta. Almost a year later, this same patient came to the emergency department, this time with complaints of chest pain. The defendant radiologist again read the chest x-ray from the emergency department and had the same impression. No acute cardiopulmonary diseases, normal cardiomediastinal silhouette, and age-appropriate atherosclerotic changes of the thoracic aorta. Later that afternoon, angiography without contrast showed a small aortic dissection. A second angiography about 12 hours later showed a type 1 aortic dissection. And the patient coded during the second angiography and died. The patient's family alleged the defendant radiologist incorrectly interpreted the most recent chest x-ray from that day's visit to the emergency department, because their expert said the chest x-ray clearly showed an enlarged thoracic aorta, and that incorrect interpretation delayed the diagnosis at least 12 hours, leading to the patient's death. The defendant radiologist testified that her training ingrained in her to review the patient's prior medical records and studies, and when she opened the new study in the patient's EMR, the study provided a list of all her previous studies. Usually she could choose and read the impressions from those previous studies, but recalled that on this day, She attempted to review those previous chest x-rays, especially the one from a year ago, but was unable to open and read them. She did not document that attempt or that she was unable to review the study. She testified that if she had been able to compare the two studies, she would have reported a change in the mediastinal width and an enlarged aorta and contacted the ED physician immediately. Instead, she documented no acute abnormalities. The plaintiff's expert witness testified that the standard of care required the defendant radiologist to document that there was a prior study she could not access and to issue a preliminary report indicating attempts to retrieve the prior study for comparison. However, the expert witnesses for some of the other co-defendants in the case testified that that prior study was unnecessary because the current study should have caused the defendant radiologist to recommend CT immediately to the emergency department physician. The defendant radiologist and the plaintiff in this case agreed to settle before the case went to trial. Susan and I have thrown a lot at you. I really could talk to you about the cases for hours. I don't know if you could stand it, but I could. So you're wondering, it's unreasonable to expect me to remember all of this, and I agree. Physicians have patients in the general public do place a lot of unreasonable expectations on physicians. And one is to remember everything that the physician has read, seen, or heard. So what's your nugget out of this presentation? The nugget is, I've worked for MICA, which is a regional company, and I've worked for a national and international company. I have worked with medical malpractice defense attorneys across the United States. I've been doing this for 25 years. No defense attorney has ever said these words. Man, the doctor just wrote too much. Oh, this is going to be a real problem because there's just too much documentation. Said no defense attorney ever. If you can remember, I hope that you'll try to make the time. I know there's not a lot of it for correct and appropriate entries. Effectively represent the patient in your documentation and effectively represent your care. Maintain the narrative. Give yourself credit for the work you do. It may seem like a small thing and not worth your documenting in the record, but it could make or break a case later on. Also, comply with any of your contractual requirements, for instance, with a third-party payor with regard to documentation in any state or federal laws. For example, you end up in a state that might actually specify what risks you might have to explain to a patient or to use a certain form. I believe that we have a slide that you can use to show that you were here today and take a picture of it. And Susan and I are available for questions, but it is 1 o'clock and I understand that you may have places you need to be.